a people issue. It's a community issue, and it's devastating. And it's sad news that we're bringing to our colleagues, but we need to do that, and the American people need to understand what's coming. The worst has not yet hit, and I yield back.
And I thank the gentleman from Georgia. You know, I have spent most of my professional career in the healthcare industry. I've represented a hospital for a number of years, so I know up close and personal how these issues have affected and will affect our hospitals and our providers. And despite the best intentions of this health care law, whether we disagreed with it or we agreed with it, despite the best intentions of this health care law, what we are seeing are the unintended consequences. The fact that our hospitals, our healthcare providers, will not be able to proceed, will not be able to perform the services that our communities need and expect and have come to expect. And that certainly wasn't the intent of the health care law, but ladies and gentlemen and Mr. Speaker, that's exactly what is happening. I'd like to yield and recognize the gentlewoman from North Carolina.
Thank you. Thank you, Congresswoman Burkle, for holding this special order tonight, along with my colleagues on the Doctors Caucus. And thank you, Mr. Speaker, for being here. You know, we are all here because we are health professionals. We know the real world of health care, and we know the real world solutions. It's the reason I'm here in Washington now, that and the fact that I'm concerned about where the future of the country is going for our children. Many times in our healthcare practice as a nurse and my husband's surgery practice as small business owners, over time, we have always looked at these issues, whether we're talking about Medicare, whether we're talking about the possibility of having real good concrete tort reform, all of these different issues that we've said, if we could put these in place, healthcare could become a much more solid foundation moving forward. We already know that we have the best healthcare in the world, but knowing, being in the industry, having that small business, understanding where Medicare, Medicaid reimbursements were going, which are down, you have to ask yourself, how can this continue? How will we be able to provide health care into the future? Well, of course, we know that the health care bill was passed in the 111th Congress, and now we are seeing the effects of it. And one of the effects, as you have pointed out, are to our hospitals. You know, it's important that we are able to articulate this to the American people, connecting the dots. When we talk about the importance of why Obamacare is devastating to physicians, it's because it affects their ability to be reimbursed for their services. When Medicare will be cut, as we know in Obamacare, it was cut by $500 billion. Today, our seniors are saying to us, we're worried that you're going to cut our benefits. Well, their benefits will not be cut by any of us in Washington. However, because the dollars have been taken out in a significant amount, Medicare will have to say, I don't know what we'll cover. What are we going to cover? And as we know, again, in the President's health care bill, the 15-person panel has been put in place. This 15-person panel will decide what Medicare will and will not pay for. That will be direct payments to hospitals. Not just physicians, but hospitals based on the services that they're providing. And if they decide that a service cannot be paid for, there are penalties that can be assessed. There are solutions to this issue. And I pointed out one would be significant tort reform, not only for our physicians, but again, for hospitals. Why is that important? Sometimes I'm afraid that we don't explain well enough to the American people why something like malpractice reform would help this situation. Well, we know that in our nation's hospitals, if you go into the emergency room, you're going to receive care, whether you can pay for it out of pocket or not, whether you have an insurance card or not, whether you're on Medicare or Medicaid. It doesn't matter. You're going to receive the care. The problem is someone does have to pay for those services because services are rendered. You go into the emergency room and many tests are ordered. Physicians order more tests because they are out of pure fear for missing something. You can't go into an emergency room and get the good care that you need to get if you cannot identify the problem. So, as we know, physicians at hospitals, physicians at doctors' offices tend to cover all their bases rather than simply relying on the medical education that they've received, the ability to diagnose with just that, with the ability of their practice. So here we are. We talk about health care costs every day and the escalating cost of it. A good contributor to that is another piece of the President's health care bill, which basically puts a tax on all medical devices. Well, think about the cost for any hospital, any provider. What do we do in hospitals? We do surgery. We provide for health care. These are medical devices. These are instruments that have made our lives better and help us to live longer, and yet now they will be taxed. This will be a tax that will have to be assessed. Someone, again, will have to pay for it. If the effort is truly to decrease the cost of health care, how can we continue by increasing the cost? It doesn't make sense. It doesn't add up. So again, the importance is, again, for us to connect the dots for the American people, to show that if we're able to pull back on Obamacare, that we're able to remove it, repeal it, as we have already voted on here in the House, then we can make the significant changes. There's one more point that I'd like to touch on, and there again, it has to do with the ability to pay for services. There was just a consulting firm, Mercer Consulting Company, just did a study which shows that 9% of employers with 500 or more workers say they are likely to cancel health benefits in 2014 after state-run health insurance exchanges begin offering coverage under the health care law. There again, once again, it will become the government paying for it, which is paid for by the American taxpayer dollars. We simply cannot continue on this path with health care or any other issue. It has to come with free market solutions, and we have those solutions, and we are ready to put those in place. And I again want to reassure our seniors who are receiving Medicare now or in the near in the future that we are doing everything we can to rescue Medicare from the President's health care bill and put those necessary pieces in place so that we can continue those services into the future that they have paid for their entire lives. Thank you again to my colleague from New York for holding this special order.
And I thank the gentlelady from North Carolina for being here this evening. Mr. Speaker, I would just like to continue on a little bit here because of my concern, and I know my colleagues have such concerns about the health and the well-being of their hospitals. They are, as I mentioned earlier, the largest employer in my district. We refer to it as EDS and MEDS. We have a large university there and some colleges, but we also have 5 hospitals in my district. So our reliance for our local economy, for our state economy is just so very important. I want to talk a little bit more about what this health care law is going to do to Medicare and going to do to our hospitals. There's $112 billion in reduced market basket updates to hospitals. There's a $36 billion reduction to Medicare and Medicaid disproportionate share hospital payments. Now, Mr. Speaker, disproportionate share may sound a little bit confusing, or we might not know what that is. I'm going to explain what that is. In a district such as mine, we have hospitals that have missions, and I'm sure across the country many hospitals have missions. They want to make sure that the indigent population, folks who can't afford insurance, who are self-pays or maybe are on Medicaid, that they have access to quality services. So the government says to these hospitals, we understand that Medicaid reimbursements or self-pay patients will not cover your services. So what we're going to do is we're going to try to make you whole with this disproportionate share. Mr. Speaker, the health care law eliminates the disproportionate share for hospitals. And so hospitals that have a high indigent population or with a high number of self-pay patients or those who are on Medicaid, they are not going to get that disproportionate share. The hospital in my district came down here. It is a large teaching institution. They made a special trip down here to tell me that provision of the health care law will bankrupt them, that they probably receive somewhere around $80 million a year to make them whole because of their mission. And isn't that what we want? We want to make sure, wasn't that the original intent of the health care law, to make sure that there was accessible care for all Americans? But here again we reach the unintended consequences and the effect that this law is going to have on our hospitals. There is a $7.1 billion reduction for readmissions, and we'll talk about that in a little bit. Hospitals in many of the ones in my district, and I know throughout this country, they're heavily dependent on Medicare and Medicaid dollars. And with that narrow margin, Medicare and Medicaid doesn't even cover their costs. And so there's such a small margin for them to operate that there's really little capacity for improvements. Realistically, hospitals, especially teaching hospitals, and hospitals that are treating the underserved cannot bridge that gap, and they won't be able to bridge that gap because of this new health care law. Hospitals must be able to invest in their infrastructure. Having such a narrow margin and or no margin operating in the red, they're not going to be able to do that. They're not going to be able to invest in infrastructure, systems improvements, new techniques to reduce hospital-acquired infections, new models of delivering health care, and electronic health records. And I want to talk about electronic health records because they were mandated in the health care law. The Affordable Health Care Act mandates that hospitals must move to electronic medical records. Now, from a patient safety standpoint, that's a good thing. But getting hospitals up to speed and getting them ready for business has a very high IT cost for our hospitals. So again, you've got this health care law mandating electronic records, medical records, and you've got these drastic cuts to our hospitals in their Medicaid and Medicare reimbursements. Would the gentleman from Georgia, would you like to?
Mr. Speaker, I thank the gentlewoman for yielding once again. And just a few minutes ago, one of our colleagues spoke also about this problem with hospitals. Representative Elmers from North Carolina, who knows of what she speaks. She works in an office with her husband, a general surgeon. They see patients every day in the office, but they also have a largely based hospital practice because it's surgery, and you just don't do that in the office. But she had listed some of the things in Obamacare, in this so-called Affordable Care Act, Patient Protection and Affordable Care Act of 2010, when it was passed a year and a half ago. We all realized that this was a new entitlement program, Mr. Speaker, and the American people need to understand that it's not about strengthening, saving Medicare for our seniors. That entitlement program is struggling mightily, and as Representative Burkle mentioned, to take $500+ billion out of that program to pay for a whole new entitlement program, Obamacare, for, in many cases, the young and healthy, and also to put some of the burden of paying for that new entitlement program on the Medicaid program, the program, the safety net program for the poor. it only weakens that program. So you've literally gut Medicaid for the poor and the disabled, and Medicare for our senior citizens, when both programs need strengthening and saving, not gutting. It was this whole idea of having Medicare for all, really, or national health care. There are all kind of euphemisms to describe this, especially, not the least of which is the name of it, the Affordable Care Act. And as I said earlier, Mr. Speaker, and I know my colleague from New York would agree with this, it is the Unaffordable Care Act. And both she and Representative Elmers from North Carolina said, look, we know on both sides of the aisle that health care in this country is too expensive. And we need to go about changes that will lower the cost and not hurt the quality. And we can do that. We have President Obama keeps denying that there are any ideas, and certainly didn't listen to the physicians in this body or the health care providers, the physicians and the nurses, that said, look, let us come over and sit down and talk with you or any of your folks in the executive office of the presidency, and let us explain, because we have, and I said it earlier, several hundred years of clinical experience. We do have some ideas, and we really believe we want to be part of the solution and not part of the problem. But my colleague who is leading the hour and doing such a great job of it, I know she will agree that I haven't been called, I haven't been invited over. I will ask my colleague and yield back to her and ask her the same question. And I know what the answer will be. But again, the important thing for our colleagues, Mr. Speaker, to understand is that the creation of this new program, this new entitlement program, so that everybody can get health care, whether they want to buy health insurance or not, is so detrimental to Medicare and Medicaid that I fear for the future of those programs. I really, really do. And that's what it's all about here tonight, to take an opportunity to explain so people really understand the ultimate consequences of this. And I'll yield back to my colleague.
And I thank the gentleman from Georgia. Mr. Speaker, I want to just emphasize again with regards to this health care law and the fact that this law, and Mr. Speaker, this is a law. This isn't a budget proposal. This is a law. Guts Medicare by $500 billion. And it should be of concern, Mr. Speaker, to our seniors, because this law, in fact, in 2014, will begin to gut Medicare. And I again would look at this chart and the Medicare reimbursements. There will be no hospitals that will be able to provide health care. If you look at what the trend is for Medicare reimbursements to our hospitals, they cannot continue to exist based on what is set forth in the Affordable Care Act. I spoke with the CEO of one of our local hospitals, Krause Hospital in Syracuse, and he spoke with, actually I should say he spoke with one of my staff, my healthcare staff, and he indicated to us today that Krause Hospital, one hospital in the district, is facing a projected loss of $18 million in reimbursement reductions. That number goes to access to care. We can have the most comprehensive health care law in the books, but if we don't have hospitals who are able to provide that care, and we don't have physicians who are able to provide that care, we will have an access to health care problems. Mr. Speaker, earlier I talked about hospital readmission penalties, and this is another concern that hospitals have to deal with. And, you know, tonight we've talked a lot about what the Affordable Care Act will do to hospitals, the effect that it will have on our hospitals, the drastic cuts in Medicare and Medicaid reimbursements, the disproportionate share being eliminated. But our hospitals are under assaults from all sides, and that's part of the difficulty. Maybe they could somehow figure out how to deal with these cuts in the Affordable Care Act, But taken in its totality, our hospitals are having a very difficult time. In fact, as I mentioned earlier, many are concerned that they will be unable to sustain and unable to continue on with their services given the whole assaults that are coming from all directions. One of the things, and this actually is part of the Affordable Care Act, it establishes a punitive policy for our hospitals when they readmit a patient. And I'll explain that, Mr. Speaker. Under the health care law, the Affordable Care Act, we call it the Affordable Care Act, we call it the Obamacare, we call it many things. But under this new law that is taking effect gradually, under this provision, hospitals' readmission rates, now this has to do with, again, their Medicare reimbursements, compared to their expected readmission rates, if even more than one readmission occurs, and that readmission means that you discharge a patient, the hospital sends a patient home, and then for some reason they have to come back. If that happens with one of 3 diagnoses within the Medicare scheme, the hospital will be penalized for all of the Medicare reimbursements, not just that one case where there was a readmission, but all of the Medicare reimbursement cases. You can imagine the magnitude and how that will affect Medicare reimbursements. The other part of this provision in the health care law is that it really doesn't discern between what's avoidable and what's not avoidable readmission. So sometimes a hospital may discharge a patient and it was premature, or something wasn't done and the patient needs to come back. And certainly that should be considered, and we should figure out what went wrong, because readmissions are expensive, and so Medicare doesn't want to pay for them, and I understand that. However, some readmissions are unavoidable, and a hospital shouldn't be penalized for an unavoidable readmission, and yet the Affordable Care Act does exactly that. The Secretary of the Department of HHS, Health and Human Services, and has the authority now to expand what were 3 diagnoses, now has the authority to expand that list of conditions with regards to readmissions. Hospitals nationwide, Mr. Speaker, are projected to face more than $7 billion in Medicare reductions over 10 years because of this policy. $7 billion to our hospitals. We began this discussion tonight, Mr. Speaker, talking about the importance to our local economies, the importance of the employment numbers, what hospitals pay into our community with their purchases and with their employees, the taxes that they give back to the community, and now we're talking about cutting them again because of this policy. You know, the issue of hospital readmission is complex, and I hope I did a good enough job tonight of explaining it. And while healthcare providers agree there's always room for improvement across the continuum of care. Readmissions occur for many reasons, and punitive action via reduced reimbursements is not only counterproductive, but it's also potentially harmful to our hospitals, to our patients, and to our communities. Mr. Speaker, as we work hard to make sure our seniors get the Medicare benefits from the system that they have paid into, and Mr. Speaker, I want to emphasize that over and over again during the course of this hour, our seniors have paid into Medicare, into the health care system, all of their life. And now, as they reach the Medicare eligibility age, they deserve to get Medicare coverage that they expect, that they deserve, and that they've paid into. But this health care law, this $500 billion cut to Medicare, is going to change that for our seniors. It's not the budget proposal in April that was a budget proposal, and you've heard my friends and colleagues across the aisle demagogue our budget proposal in April, saying we want to cut benefits to seniors, Medicare and Social Security. The fact is, Mr. Speaker, this health care law passed into law in 2009 will devastate Medicare, and our seniors, Mr. Speaker, should be very, very concerned about this Affordable Care Act. Not only will it affect our hospitals, as we spent so much time talking about tonight, but it will also affect the care and the access to care for our seniors. Hospitals, Mr. Speaker, already operate on such thin margins, and we talked about this earlier, that for many providers, especially specialized programs, treating patients struggling, say, with substance abuse or helping the developmentally disabled, they will be reduced or they will end those programs. Hospitals have to, they cannot operate on such a thin margin and then run the risk of all of these devastating Medicare and Medicaid reimbursements. Mr. Speaker, I also want to talk tonight a little bit about graduate medical education. As I mentioned earlier, Mr. Speaker, I was an attorney in Syracuse, New York, and I represented a hospital that was a large teaching hospital. And so I know how much they rely on what's called graduate medical education. We often refer to it as GME, sort of the acronym for it, the initials. And I'm going to explain what GME is because it's so important to our hospitals. And even hospitals that don't have a medical school attached to them will talk about some of the reimbursements they get because hospitals train within their, or medical students and residents train within these facilities. Graduate medical education is the training medical school graduates receive either as a fellow or an intern or a resident. Medicare is the largest contributor to the GME. Now, why do I even bring this up? And I bring this up because we talked earlier about the many assaults on healthcare providers, the many assaults that hospitals are concerned about. This is not per se in the healthcare law, so I want to make that clear. But many, when it comes to cutting, when it comes to finding and helping this terrible national debt that we have that is now $15 trillion, often we look to Medicare. And one of the areas in Medicare, and it's what we, you know, the low-hanging fruit, whether it's a hospital or a physician, that seems to be the easiest place to go to rather than really looking at our healthcare system, making it a free market, allowing the market to compete, getting the government out of healthcare, and letting the free market, letting us folks buy insurance across state lines. Rather than letting the free market in it, we have the government involved. So Medicare is the largest contributor to this GME. GME payments, as I mentioned, have been targeted, they've become a target for recommended budget savings. In 2010, the President's Simpson-Bowles Deficit Commission recommended limiting hospitals' GME payments to 120% of the national average salary paid to residents in 2010, and reducing another reimbursement that hospitals get, the indirect IME, the indirect medical education, by 60%, from 5.5 to 2.2%. Mr. Speaker, these two changes, Medicare reimbursement to the GME, Medicare reimbursement to the IME, would reduce Medicare medical education payments by an estimated $60 billion through 2020. $60 billion. Mr. Speaker, these aren't just numbers. These proposed cuts would endanger the ability of teaching hospitals to train physicians. We must face the facts that cuts to graduate education would result in fewer practicing physicians and ultimately reduced access to care, which is getting back to why there was an Affordable Care Act. I talked about this road paved with good intentions. And now what we are seeing is that our hospitals, our healthcare providers, and the training of physicians are both going to be significantly and severely impacted to the point where access to healthcare becomes a problem. And so seniors, not just seniors, but all Americans, will have to begin to deal with the fact that primary care physicians, there won't be as many of them, there will be fewer doctors being trained, and for a number of reasons. The GMEs and the IMEs going to hospitals, if there's any reimbursement reductions to those, but also the fact that if a physician goes through all those years of training, and he goes through 4 years of college, 4 years of medical school, an internship, 3 years of a residency, and then if he's a fellow because he wants to specialize, all of those years, and then they go into practice, and you see what the Affordable Care Act, you see what all of these assaults are doing on our Medicare and Medicaid reimbursements to physicians as well as our hospitals. Hospitals that are primarily teaching hospitals face an additional challenge that could threaten the stability of their institutions. Hospitals have residents in an improved graduate medical education, again that GME program, receive an additional payment for Medicare discharge to reflect the higher cost of care that because they are a teaching hospital, their cost of care is higher. The regulations regarding the calculation of this additional payment, and I talked about this earlier, is the indirect medical education. This is all very complicated, but what I want to say and what I want to make clear, Mr. Speaker, is that if these cuts go through, it has been estimated that it will cost GME and IME reimbursements from Medicare $60 billion. This could mean a loss of 2,600 jobs and $653 million in state and local revenue, and, Mr. Speaker, $10.9 billion loss to the U.S. economy. At current graduation and training rates, the Association of American Medical Colleges projects that the nation could face a shortage of as many as 150,000 doctors in the next 15 years. 150,000 doctors. We talked about this, and I think whether you're on one side of the aisle or the other, whether you agree with the health care law, we all agree that we want to have, in a country as rich and as generous as ours, we want to have access to health care for all Americans. But if we don't have physicians to provide that care, and this estimate is 150,000 doctors in the next 15 years, a shortage of that many, it will discourage this access to health care and will result in longer waiting times for patients. Mr. Speaker, in closing, I want to just emphasize a few points this evening, and it's always an honor to be here on the House floor. It's always an honor to talk to the Speaker. And tonight it's been an honor to be able to address health care. As a health care professional, I spent years as a nurse and then, as I mentioned, as an attorney representing a hospital. I know that people within the health care profession are dedicated. They have a passion to provide the American people, to provide any people with quality health care, to make sure and ensure that they have quality health care. And you know, Mr. Speaker, the United States of America has the best health care in the world, and so it is so imperative that we preserve this health care system. My colleague from North Carolina mentioned earlier that we voted to repeal the health care law, the Affordable Care Act, because it's not in the best interest of good health care. And tonight you heard, Mr. Speaker, from several of my colleagues who are health care professionals who dedicated their whole lives to providing medical services to the people in their communities. They care about quality health care. They care about people, and they care that the United States of America has a good health care system. But we don't believe that good health care, access to health care, reasonable costs within health care are going to result from the Affordable Care Act. The Affordable Care Act, I want to emphasize this one more time, Mr. Speaker, cuts Medicare to our seniors by $500 billion. To our seniors, that will be a devastating blow to the services and the access to services that you will have. But beyond that, it affects how our hospitals can provide care, how our hospitals will be paid, how our doctors and our young doctors will be trained for future generations. This Affordable Care Act may have been the most well-intentioned law, but it is devastating for health care and health care delivery services in the United States of America. Mr. Speaker, hospitals serve us in our communities. The crafting of the Affordable Care Act was carried out with the good intentions of many. As I said, I don't want to indicate or imply that people didn't have good intentions with this Affordable Care Act, but they approached it from the wrong direction. They put the government in the middle of a physician and the patient, and that can never work. But good intentions are not enough to excuse legislation which has a terrible and far-reaching, albeit unintended, consequence for all sectors of our society, especially our patients, our doctors, and our hospitals. Mr. Speaker, I yield back.
Under the Speaker's announced policy of January 5th, 2011, the Chair recognizes the gentleman from Texas, Mr. Gomer, for 30 minutes.
Thank you, Mr. Speaker. One thing we got plenty of around here is paper, unfortunately. We got bills, we got laws that we should have taken up that we haven't. And when we talk about the health care bill, people know we talk about Obamacare, whatever the formal name is, cutting $500 billion out of Medicare already. That's a done deal. That was rammed through by the majority when Speaker Pelosi was in charge at the behest of our President Obama. $500 billion in cuts. Our seniors deserve better than that kind of treatment. Republicans, I don't think we had any Republicans vote for that. But it was driven through against the will of the American people and against the will of the Republicans. But Democrats had the vote, so they did it. $500 billion in cuts to Medicare. So when AARP has all these seniors send in petitions saying, I'm a member of AARP, don't you dare cut anything from Medicare, we try to make sure our seniors know that it was Medicare that stood by the President as he cut $500 billion, and we're glad that they're finally waking up to just what the President and AARP, with AARP's assistance, what they did to seniors. But if you look at how much money we are spending on Medicare, not to even mention right now Medicaid, just look at how much we're spending on Medicare, and you look at the number of households we have, around 17.5 million Medicare households. This was from 2009. You divide that into the amount of money that we're spending, federal government spending on Medicare, not even Medicaid, just Medicare. We're spending right at $30,000 for every household with somebody on Medicare. $30,000? Now, for someone who's got bad heart problems or some kind of chronic disease, well, that's not so bad when you consider what all kinds of treatments and medicines they're getting. That's if you look at the bills that are sent out. If you look at the amount of actual money that are paid for those procedures, or actually paid or reimbursed by insurance companies or the government for that money, it's not near that much for most households, even most households on Medicare. So I was shocked, not too distant past, to find out that in one situation that I'm aware of personally, when there was $10,000 between the $10,000 in bills between the hospital, the physicians, the ambulance, the testing, the people reading the testing, all that stuff. 2 days of hospitalization, $10,000. It turns out that the insurance company, the health insurance company, resolved all 10,000 in bills for about $800. Well, if we knew exactly how much was being paid to pay for those exorbitant health care bills, we could then finally reintroduce something known as free market principles. Now, the doctors I talked to, the health care providers I talked to, they wouldn't mind that. Their hands get tired. There's some insurance policies or contracts that health care providers have with some of the health insurance companies that say they cannot charge, that's what I'm told, they can't charge somebody paying cash as little as a health insurance company providing the contract gets out by paying. You can't have competition in health care until people know how much they're paying for their medicine, for their hospital stay. You got to know what they're paying. It was a great thing growing up in a small town in East Texas. I love the town, Mount Pleasant, Texas. After I finished 4 years I owed the Army from a scholarship at A&M, Texas A&M, my wife and I settled in Tyler. We've loved it. It's the only home my kids knew growing up. Been so good to me, but my wife and family, we've all been blessed there. But in the smaller town I grew up in, everybody knew the doctors, and time to time we'd go to different doctors. And a lot of times it was because find out one upped their price, so we'd go to another doctor, didn't charge quite as much because they were good. That's called free market competition. We don't have that anymore in health care. We got to get back to it. If we're going to bring the costs down, we got to get back to it. People got to know what it costs to go to the doctor. People need to know that their medicine that they see a cost of $900, that the insurance companies, when they reimburse for that $900 prescription, don't pay but a fraction of that. So if somebody can't afford insurance, why should they have to pay $900 for a prescription drug that a health insurance company wouldn't pay a fraction of that much? We got to get back to having some competition in the costs of things. So there's one way, really the only way I see that we get off this track to total socialized health care that Obamacare puts us well on down the road toward arriving on, and that would be through greater use of health savings accounts. We're told by some actuarials that if kids in their 20s and 30s start putting money in a health savings account and it grows and grows because they don't use much at that young age, and by the time they're eligible for Medicare, not only would they not want to use Medicare, they wouldn't need it. They'd have so much money built up in their health savings accounts that they didn't get through every year. And I agree with some of the people that I've consulted over the last 4 years on what would be a better plan, that if you could have people putting money every month in a health savings account, building that account, then not allow it to be drawn out for something like buying a boat or anything like that, but it has to be for health care. Can't be for anything else. Once it's dedicated in a health savings account, and it should be allowed to be put in there pre-tax, then it has to be for health care. Oh, sure, we ought to be able to allow people to donate that to some charity that keeps health savings accounts for the less fortunate. Ought to be allowed to gift it or bequeath it to children, to family, and help them grow that big nest egg of a health savings account. And then you have a debit card coded to cover nothing but health care costs, and you use that health savings account until you reach the amount of the high deductible that the health insurance policy has, and then the health insurance kicks in. That would help make health insurance so much cheaper for most folks. It's what a lot of us have gone to, and I have myself. It's a lot better deal. It's a lot cheaper. But to think about, as these numbers indicate from 2009, that every household with someone on Medicare is costing nearly $30,000. It's just staggering. And that's why, instead of continuing to move toward ration care, putting our seniors on lists where they can't get treated very quickly, they have to wait, because let's face it, the way of socialized medicine is ration care. And President Obama not only must have known that that was the truth, but he put a man in the position to oversee Obamacare who had made clear in prior statements that it's not a matter of if we go to ration care, it's a matter of when. And then he's the guy that ends up in charge of Obamacare, because obviously this president and the Democratic majority in the last Congress expected that seniors would be getting ration care. How much better to say, you know what, seniors, you got a choice. How about that? We've had so many people on the Democratic side of the aisle talk about it should be people's right to choose. They should have choice. Well, how about in health care? How about giving seniors a chance to choose? You want Medicare? You want to be denied some medicines? You want to have to keep buying that supplemental coverage from AARP? Your choice. On the other hand, if you want to do something different, we'll put, and I'm flexible on the amount, but it appeared $3,500 was a good, effective amount for achieving that kind of high deductible and lower costs for the insurance policy. Then we will buy you, the federal government will buy you a private health insurance policy that covers everything over $3,500, and then we will give you cash money in a health savings account, the debit card to go with it, that you hold, you use as you see fit. You choose what medicine, you choose what doctor, and when you exhaust, if you exhaust the $3,500, then the insurance kicks in and you got that coverage. You don't have to buy supplemental coverage. And I know that would cost AARP hundreds of millions of dollars. I get that. And I know they care deeply about retired folks. I get that. But, boy, if retired folks wouldn't have to pay anything for supplemental insurance, it seemed like that'd be a good thing. We give them the choice. Let seniors choose which you want. You want control of your own health care and the money to pay the deductible if you get that high, and an insurance policy to cover everything beyond that. If you go beyond that, you control things. Or do you want to let the government keep telling you what you can and can't get in the way of treatment? The country is better off when the federal government is the referee, not the player. Because government's always going to be the referee, but when it's the player and the referee, that's when it's so grossly unfair. Anybody should be able to figure that. That would be so much better for seniors. Give them the choice. But you know what? This president, Speaker Pelosi, Leader Reid, they felt like they knew better for seniors. They felt like it would be better if they did not allow seniors to have a choice. Too bad. Seniors, we're going to cut $500 billion from the amount of money that we're expending on Medicare, and you're about to find out what real ration care is about once Obamacare kicks into the full. Why not give them a choice? Why not force doctors and health care providers for the first time in decades to start posting what the cost of health care is? How much at your hospital is a hospital bed? In a single room or in a double room with 2 patients in there? How about showing people that? Letting them decide which is cheaper. Because as long as an insurance company or the government is paying all those costs, people really don't care. That's the way of the world. That's why in the Soviet Union in 1973, when I asked some farmers in the middle of the morning who were sitting in the shade visiting instead of being out in the field working, and I tried to do it as nicely as possible, spoke a little Russian back then. When is it you work out in the field? They said, the loudest one said, I make the same number of rubles when I'm in the shade here or if I'm out there, so I'm here. That's socialism. When the federal government socializes medicine, as Obamacare is driving us toward, just one giant step, we're virtually there. Well, then it changes everything. People don't really care how much things cost because they're not paying them. People don't try to go to a less expensive doctor or hospital because they don't care. Somebody else is paying it. And then when they see the bill that, gee, this stay costs $10,000, they think, well, gee, I'm glad I'm not paying that. But they don't care because they're not paying it. They don't know that there may have been $200 paid for that hospital bed rather than $10,000. People deserve to know what health care costs. And as I say, the health care providers, the doctors I talk to, they wouldn't mind being able to do that. They would love it if patients could come in and give them a health savings account debit card and they don't have to have extra people that are chasing down the new codes and all this information about what the government pays, what the insurance company will or won't pay. We'll get back to a doctor-patient relationship. Wouldn't that be wonderful? As I've told health insurance companies before at a convention here in Washington, D.C., we need to get the health insurance companies back in the health insurance business and out of the health management business. Because if health insurance companies are determined to stay in the health management business where they manage our health care, they're eventually going to have everybody mad at them. They're going to be run out of business, and there won't be any health insurance companies anymore other than the socialist federal government of the United States. I don't want to get there. We are almost there with Obamacare. That's why this body, with majority Republicans having taken over this year, voted to repeal Obamacare. But real health insurance, when it's real insurance, people pay a small monthly, quarterly, semi-annually, annually fee in order to insure against some unforeseen disease or accident down the road. Unforeseen because if they could foresee it, they'd know how much they need to save to take care of that event that's coming or the disease. But you pay an insurance company for something you don't know might happen. Maybe it will, maybe it won't. And the thing is, if we went to the place where we allowed those on Medicare to choose, stay with Medicare if that's what you want. Keep buying that supplemental insurance. Or we'll give you the cash in a health savings account and a debit card. We'll buy the insurance to cover everything over the cash we put in your account for the year. And we'll do that every year. And when I was drafting the bill in the prior Congress, Newt Gingrich was very helpful. He sent a couple of experts to come visit about ideas. And they said, you know, we ought to have an incentive in the bill so that seniors would have an incentive not to spend all the money, the $3,500 that's put in their HSA every year. So we put in a provision that if someone on Medicare didn't use up all of the $3,500 in their health savings account, then they got a percentage of that cash money that they could take. It was no income tax would have to be paid on it, just cash money in their pocket at the end of the year to encourage them not to waste money from the health savings account buying stuff they didn't need, because they were going to get a percentage of that if they didn't spend it at the end of the year. Give them incentives. It's what market forces are about, incentives. Now, if we were to do something like that, then certainly there are people who are chronically ill. We will always have people who are chronically ill. And those are the people we should help. They can't help themselves. That's what a caring society does. But when there are people who are able to help themselves, then those are the folks that ought to be able to grow a health savings account over the years so that they don't need any government help by the time they get to the point where they're eligible for Medicare. If they need it, they'll get it. But that would finally get us on track to get out of this massive amount of debt that we're in. That's the way to go. But in the meantime, not only is that not something that's occurring, we're not able to innovate new things that will become law. We're innovating new things like the alternative to Medicare, the choice we could give seniors. But we know that as the President's called us, and it really only applies to the other end of the hall, we got to do nothing Senate. Not the Republicans. They keep clamoring, trying to push, trying to get the Democratic leadership in the Senate to do something to help the economy, truly, do something to help health care. But they're not interested in doing that. We've got a super committee, as it's been dubbed, that we really shouldn't have set up. And I have nothing but sympathy for my Republican friends that have been put on that committee, because they were put into a position where, unbeknownst to our Republican leadership that negotiated the deal that brought this committee about, the Democrats really don't have anything to push them to reach an agreement. That appears to be why the Democrats seem to be interested in what Pat Toomey had floated out as a framework with the support of his colleagues. They seem to be interested in it, but apparently after consulting with Democratic leadership, they realized, uh-oh, we're told not to work a deal, because if we don't work a deal, there are draconian cuts to our national security, which we don't mind. We've been wanting to do that for years. And then the other cuts will be to Medicare. And apparently, because of the lack of interest by the Democrats in seeing that there's a deal done, it would appear they don't mind having the cuts to Medicare. And that's what was puzzling me last week. Why is it that the Democrats on the super committee, after they hear how far backwards Republicans were willing to go on the super committee, how is it that they end up walking away from basically what they wanted? And so I struggled to try to figure out what it was that would keep them from being desperate to cut a deal with Republicans, because surely they don't want those cuts to Medicare. And then I realized, well, Democrats are 100% totally responsible for the $500 billion in cuts to Medicare that are contained within Obamacare. They also know that millions of dollars of Republican campaign money will be spent next year, probably talking about the $500 billion in cuts the Democrats solely on their own pushed through in Obamacare, and that unless there is at least a couple $100 billion in cuts to Medicare, that at least that amount would result from a failure to pass some kind of bill from the super committee. Unless there's something like that, the $500 billion that the Democrats cut Medicare last year is all anybody's going to be talking about in the next election. But if the super committee fails, the House and Senate don't pass what they've sent, then we've already seen the rhetoric begin. Republicans, they say, are wanting to cut health care, wanting to cut Medicare. So now we see how it's playing out. Some apparently on the Democratic side, not all, but some, apparently the leadership of the Democratic Party, apparently the president, want to see a failure so they can campaign against Republicans saying, they didn't want an agreement anyway, and look at the cuts to Medicare that they forced. I don't see any other explanation for the cavalier attitude of the Democratic leadership in not pushing so hard to get an agreement to avoid the massive cuts to Medicare. Even with the massive cuts, it won't be as big a cut as Obamacare was to Medicare. But it will be enough, apparently, for them to campaign and try to demonize the Republicans. Now, apparently tomorrow we're going to vote on a balanced budget amendment. Okay, thank you. It'll either be House Joint Resolution 1, House Joint Resolution 2. House Joint Resolution 1 has a cap on spending. We can't go above a percentage of gross domestic product requires a supermajority in order to raise taxes. That's House Joint Resolution 1. That's what passed out of committee after a long and exhausting day of debate and amendments. But we're bringing to the floor House Joint Resolution 2. It just says you got to balance the budget. I know there are those that say, well, that would mean that our decisions start being made by the courts. Well, 49 out of 50 states, as I understand it, have a balanced budget requirement in their constitutions. Their courts don't make those decisions. I don't see why it would be otherwise. If it was, under the Constitution, we got the power to restrict jurisdiction for everybody but the Supreme Court. We could do that. That's what we chose to do. We're in a mess because we're not doing the things we promised we would when we ran and got elected to the majority, the very things that Democrats lost the majority in this House because they didn't fulfill. It's time to get serious about our promises. Everybody is aware of Francis Scott Key writing our wonderful national anthem. My time runs out. I want to finish tonight with something else that Francis Scott Key said February 22nd, 1812. He said this, quote, "The patriot who feels himself in the service of God, who acknowledges Him in all His ways, has the promise of Almighty and will find His word in His greatest darkness, quote, a lantern to his feet and a lamp unto his paths," unquote. Francis Scott Key continues, he says, "He will therefore seek to establish for his country in the eyes of the world such a character as shall make her not unworthy of the name a Christian nation." We've got a lot to do if we're going to live up to our commitments, our oaths. A balanced budget amendment with a spending cap is what we needed to do. That's what we passed out of committee in regular order. That's what I would vote for tomorrow. Since that's not coming, then I don't want to push through a balanced budget amendment that requires ever upward spiraling taxation, because as we've shown this year, without a balanced budget amendment, Congress doesn't have the will to cut spending, not a majority of the House and Senate both. It's time to live up to the commitments we've made and what we owe our Creator, our Maker. And if we'll do that, we can have another 200 years of greatness as a nation. And if we don't, as Abraham Lincoln said, this nation will die by suicide. I want it to live and flourish. I want us to keep our commitments. And with that, Mr. Speaker, I yield back.